Hi, everybody. Welcome to the program today. I am Mary-Beth Newell, one of the Senior Vice Presidents of Clinical Reimbursement at Limitlessli. And a couple housekeeping items to start with. Everyone is muted. If you want CEUs, please in the registration, make sure that you included your license number so we can give you CEUs. And then in case you're asking about the slides will be sent to everybody after the program is over. And then I have my helper, Yvonne Rickert, who is our COO. She's going to be helping with the chat. So if anyone has any questions, you can put it into the chat. And hopefully we'll have a few minutes at the end of the program to answer any questions. So today we're having QM training and management of behavior disorders. Our objectives are that you'll understand how the QMs are triggered for the psychotropic medications and behaviors and how they can impact your 5-star rating. We're going to explore how to conduct behavior and psychological symptoms of dementia assessment and analysis. And I'd like you to acquire some knowledge about non-evidence-based, non-drug interventions, how to create a life story, and ways to help the staff to become sensitized to the residents' realities and challenges. Okay, so we have the quality measures. So there are some of these that impact your 5-star, which is new antipsychotic use, which is for your short stay residents, and then antipsychotic use. There's another one for long stay residents. And the surveyors also use some of your QMs when they're looking at who they want to pick for the sample or what they might want to focus on. So they also look at your percentage of anti-anxiety and hypnotics as well as behaviors. So that all comes off of the MDS if you didn't realize that. So for a newly received an antipsychotic for your short stay, the way it triggers is if on your initial MDS you did not code an antipsychotic, and then you code an antipsychotic within 100 days of the resident's stay. Now, there is exclusions if a resident has a diagnosis of schizophrenia, Tourette's, or Huntington's disease. They will not go into the numerator. And then the anti-anxiety and hypnotic use, it will trigger if you code anti-anxiety or hypnotic on the MDS. And there are some exclusions. So if the life expectancy is under 6 months or you've checked hospice, the resident will not trigger for that. Now, remember, if you have palliative care, they might have written, if a practitioner writes that the anticipated life expectancy is 6 months or less, sometimes you'll see that if you have a palliative care consult, you would code that in section J. So it doesn't mean the resident just has to be on hospice. You can have either of these. And then the surveyor quality measure, these are also things that will exclude a resident, these diagnoses here. And then behavior symptoms affecting others. So the way this triggers is from section E, if you have physical or verbal behavior directed towards other or other behavioral symptoms, rejection of care or wandering. And the only exclusion, and this is one that the surveyors use, so it's not part of your 5-star, it's one the surveyors use, but the only exclusion is if it was an over discharge MDS. And then we have the new hybrid antipsychotic use for long stay residents. And this was introduced in January. It triggers if a resident received an antipsychotic. So it's either marked on the MDS or a claim was filed for an antipsychotic medication. So if the pharmacy, and this is interesting because some residents have never received the antipsychotic with a long stay, but maybe it was ordered PRN and the pharmacy delivered it. Well, there is a claim for that drug, and those residents are now triggering. So you just want to be careful about those PRNs. And there are some exclusions. So if the resident has schizophrenia, Tourette's, or Huntington's, and there is a claim, so a practitioner issued a claim for their professional visit and included one of those diagnoses, the resident will not be included in the numerator. Or if there's a hospice claim, not marked on the MDS, but a hospice claim, the resident in the quarter, the resident will not trigger, or a resident is not continuously enrolled in Part A or Medicaid for 12 months or longer. And really, at this time, the only way to see if a resident is excluded or is triggering is going into the I-keys, pulling up your resident level quality measures. And there's a whole section as well as a key to let you know if they did trigger or if they were excluded, why they either triggered or were excluded. Okay, so what are some of the side effects of antipsychotics? I don't know if you realize there is a 5-time greater mortality for older individuals who are taking an antipsychotic. Some of these we already know. We know that it can lead to falls, weight gain, they might be tired, but some of these other ones, again, increased risk of a stroke or TIA, the Parkinsonism symptoms can be a side effect. It can put a patient into type 2 diabetes, urinary incontinence. Now, sometimes there's a reverse effect. Sometimes you're giving these and you want the resident to calm down, and it can have the opposite effect where they can become hostile. So that's something to keep in mind as well as water retention. You can see the other side effects there. So what's some of the background? I'm going to give you some background on residents with dementia. So currently there's 5.8 million people in the US with dementia. The most common for the BPSD that we're seeing is verbal and physical aggression. They have sleep disturbances, restlessness, and wandering, and it is $321 billion that we spend on dementia care, and 90% of the residents with dementia are going to develop significant behavior problems, and usually it's the aggression, the wandering that leads to a resident being admitted to a skilled nursing facility. So we're going to focus a little bit now on behavior and psychological symptoms of dementia. It's referred to as BPSD. So there's behavioral aspects such as physical aggression, loud vocalization, restlessness, agitation, and wandering. And then there's also psychological. So the patients can become anxious or depressed. They might have hallucinations or delusions. So I'm going to talk about Betty. And then later on, after we go through some things, we're going to revisit Betty. So Betty is a resident. She wanders and goes into other rooms. She won't eat in the dining room. She takes off her clothes, sometimes in the day room. She refuses to get out of bed or have her brief or sheets changed when she's incontinent. She angrily accuses staff of stealing her belongings. She stays up late, wants to sit at the nurse's station. She's in a really bad mood in the morning, lashes out at staff trying to get her up, and repeatedly asks when she's going home. So like I said, we'll revisit Betty a little bit later on. So to do a BPSD assessment, there are 4 steps to it. So first is to rule out delirium. The second step is to identify possible triggers. Then we want to identify the target behavior and then review the case and develop interventions that are individualized for that resident, might be Betty. So to rule out delirium, this is the first thing you want to do to make sure the resident is not having these because of a delirium, which is a medical emergency. So looking, is there a medical condition, something that's going on with the resident? Is there encephalopathy? Are they having a CVA? Do they have an infection, a respiratory infection, or a UTI? Make sure it meets the McGear's criteria, because a lot of patients just grow bugs and don't have a UTI. You want to check the vital signs, listen to the breath sounds, review for an impaction. We know that a lot of times patients will have behaviors they can't tell us that they're constipated or have an impaction, but a lot of times their behavior is telling us there's something that's wrong. And then certainly any lab work or radiology to rule out the delirium that might have been ordered. So some of the things you want to do is, everyone has their clinical meetings where you discuss the residents. You want, like, that resident might have an impaction or be constipated. You want any alerts, and you want to connect the dots so that if there's a change of condition, or if you're using the stop and watch system, the interact stop and watch, where the nursing assistants are alerting the nurse if there's any kind of a change in a variety of areas with the resident, so that we can intervene early and assess that resident before it ends up that they need to transfer to the acute care hospital. So a patient might be eating less than 50% of their meals, which is a change. You might want to do a more advanced clinical review, and then certainly antecedent behavior monitoring, which I'll be talking about, is another thing that we would like to do. So in order to identify the target behavior, there's a lot of these questions, and it really helps to narrow down and identify what is it, when is it happening, who is it happening with. So with the behaviors, when did it begin? How often does it happen in the day, at night? How long? Is there a certain location? Is it happening in the dining room or the resident's room? What's the impact on the resident or others? Can you identify any precipitating factors? And also, when does it not occur? Okay, so that can be important too, that maybe the behaviors are never with Susie, the CNA, but it's occurring with everybody else. So then we'd want to go to Susie and find out what Susie's doing, because she may have an intervention that she's using that is effective. So we want to collect the data, and there's a lot of different things we want to look at. I'll talk a little bit about a life story that lets us know a little bit more about the resident. What are their coping mechanisms? The resident might not be able to tell us that, but their family might be. What's their preferred environment? Taking a look at the medications. Are they in pain? And then really listening to the resident, if they're, for whatever they're able to tell us, and the family that knows the resident. So this is an example of an antecedent behavior monitoring log. So what you want to do, and this is just a sample, you might have something, or you might want to come up with something a little bit different, but basically you're recording for a period of time, the date, the time when these behaviors occur, where was the resident, okay, the location, what happened immediately before the behavior, what was the behavior? What did the resident say or do? What did we do to try to intervene? And what was the response? And then the initial of the staff member. So for the most part, this will probably be your nursing assistants. It may also be, if they're in activities and something happens, you might have your activity director. So we really want to identify the behavior, if there's anxiety, delusions, hallucinations, increased confusion, or disorientation, so that we're doing some detective work. So when you have that done, and I would say at least for a week or two, you can review the monitoring to really see, are you identifying any trends? Also, are there any other people that were involved? So looking again at the resident, were they unwell? Were they in pain? Did they seem to be uncomfortable? Were they overtired or stimulated? Did they seem scared, anxious, frustrated, embarrassed, feeling patronized, ignored? Again, the delusions, hallucinations, or do they seem to have a depressed mood, or were they bored, understimulated, or not having any social contact? And then try to figure out if it was a reaction to an unpleasant incident or association. So maybe it's happening when the resident's getting showered. Maybe it happened with a male CNA, that maybe there's some association with males, that the resident has had something happen in their past and they don't like males taking care of them. Were there any personal dislikes or fears? Was there a change in that was happening with the resident, a change in the environment? Or is there a memory that they have of something? Or were they being provoked, or was there a conflict with another resident's personality? Might even be a staff member. So identifying possible triggers, it could be an unmet physical need. We talked about pain, constipation. No, they might be cold. They might be hungry. They might be thirsty. They might have an injury. That's another thing that the resident might have a ingrown toenail. Maybe they have a toothache that they can't really explain to us. Is there an iatrogenic cause, such as an inappropriate med or a side effect of a med? So you might want to get your pharmacist involved to look and see what's going on with the resident, if that could be a side effect of any of their meds. Environmental, is it noisy? Was there over understimulation, or did the resident want to wander and there wasn't any space to do it? Or psychosocial, boredom, loneliness, or how's the staff communicating with the resident? And some other things to think about: if a resident has a low sodium or calcium level, that is associated with anxiety or confusion. So we talked before that you might want to get some lab work. And then residents can also become agitated if they're starting to have an exacerbation of CHF, if they're having a heart attack, or if an abnormal blood sugar. High blood sugars are associated with more aggressiveness and agitation. So those are some other things to think about. Unmet physical needs. We already talked about pain or discomfort, an infection. Another behavior associated with a UTI, but remember, you need to make sure it meets the Beginner's criteria as much as you can, but screaming. So a resident may be having burning on urination and screaming to express that they're in pain. So that's something to think about. Residents who get up and wander at night, that can be associated with cardiovascular disorders. So is something going on with their cardiovascular system? And then if they're having arthritis and pain, you can also see agitation from the arthritis that isn't well controlled. So those are some things there, as well as fatigue. Maybe they can't see all that well, or they're hallucinating. So for pain, these are areas that for nonverbal, okay, I think we're pretty much aware if they're rubbing or pulling at a body part or clenching their teeth. They might be huddled and rocking. Okay, they might be experiencing pain. Their appetite might change. Usually, if you're in pain, you're not very hungry, or they might be more restless. So the different things that we want to be assessing: is there any new swelling or inflammation? What's their temp? Is there an existing injury? Again, looking at the constipation. Do they have a diagnosis of arthritis? Are they on routine pain medication? Checking the toenails and fingernails. Is there something ingrown that's causing pain? And then trying to identify if there might be a toothache, earache, or how are their dentures fitting? Are the dentures causing a problem because they're ill-fitting? Now, an iatrogenic cause, you want to avoid what I call the antis. Okay, so it's not like Aunt Dolores. It's anything that starts with ANTI, such as an anticholinergic. And these are common meds that can cause side effects. So the bladder instability meds, some of these amitriptyline, hydroxyzine, anticonvulsants, antidepressants, especially tricyclics, as well as antipsychotics, some of the anti-Parkinson drugs, antispasmodics. Now, you might not be able to avoid these. If somebody has Parkinson disease, you might need to give these, but think about if a resident is on any of these meds. Do they truly need it if they're having BPSD going on? Or is there another med that might be a better choice? Or can we get them off of it? And then also DIG, statins, and some calcium and antagonists are associated with behaviors, corticosteroids, usually with the dose, and then sometimes hypnotics and sedatives, especially benzodiazepines and opioids, can have side effects. The other thing that I don't think people realize, anticholinergic drugs reduce the cholinergic neurotransmitters. Now, if you're giving a patient a drug like Aricept or Namenda, those drugs want to increase cholinergic neurotransmitters. So if you're giving an anticholinergic, you're working against the dementia drug. So that's another thing to keep in mind. And sometimes a patient will have a medication-induced dementia. So we want to double check. Did the behavior start after they started on a med? And we're trying to put two and two together, but looking at that as well. And then environmental, overhead noise, call bells, intercoms, pages, chair alarms, the pill crusher that's making a bunch of noise. If you have an elevator with a bell that goes off, is the nursing station phone constantly going? Do you have a fax or copier machine that's making a lot of noise in the residence area? And sometimes they think it's like a disembodied voice. They're hearing an overhead page. It's like, where is that coming from? Or sudden noises that are unexpected could cause a resident to become fearful and maybe have some behaviors. Really pay attention to television shows and commercials. Is there gunfire or screaming, maybe in a Western that someone has on, or loud, angry voices? And if you have dementia, and you're hearing that can be frightening. You don't know what's going on. So we want to think about what's on the TV. And is it happening when the resident's in the day room, or is that's what's on TV in their room? And we need to think about changing the station. Also, the atmosphere, the tone and volume of the voices of staff, as well as other residents. And what is it like? Is it hectic, harried, all this stuff going on that stresses people out? Or is it a relaxed and inviting environment? Also think about, is it too bright for people? And what is the temperature? Is it too hot or too cold? So those are things from an environmental aspect we really want to be thinking about. Psychosocial needs. So I'm not going to read every single thing on here, but a few that we know that patients can have behaviors if they feel like they're being stopped from doing the things that they want to do. They get frustrated, but they also might feel like they're not being listened to and get angry, or their rights aren't respected or being ignored. They might find personal care threatening or invading their personal space. They might not be making any decisions and feel like stuff's just being done to them, not that they're involved in the process. They may have a completely different reality. We know that can happen with our patients. And they also tend to have a loss of inhibitions, and their judgment, we know, can be impaired. Let me go back. I want to go back. Well, I'll just talk about this. So with some of the psychosocial needs, what we want to do is we want to focus on what the resident can do. Okay, let's emphasize the positive. And you want to understand their past. If someone was mugged in the past, they might really have become aggressive if someone's approaching them from behind, because they had that it's like a PTSD thing going on. Or a resident may be upset and they're not always able to tell us this stuff. You might have a gentleman that always wore a suit jacket and a tie. Wearing a tie is part of their identity. And if you're not putting the tie on, they can be getting upset because that's part of their identity and who they are. Another thing where the residents can get upset. Think about, if a resident needs their food cut up, are you doing it at the table like you would for a toddler? Or do we cut it up away from the table where other residents are, and we present it with it cut up, which is really respecting them as adults? And we might not even be thinking of these things, okay? So that's something you want to think about if a resident gets upset because they feel like you're treating them like a toddler, you're cutting up the food on their plate in front of everybody else. And then just remember, a lot of times the patients, they don't know who you are, what you want to do. Okay, so we need to slow down, introduce ourselves calmly, softly explain to the resident what we want to do. So sometimes we just rush in there to do it, and we're not really thinking about the resident's reality. So when we get to the point number 4, where we're going to do the case review, like I said, we want to review the data. You might want to take it to your behavior management committee so you can have an interdisciplinary people looking at it. Think about non-drug interventions that I'm going to talk about that you might want to use. And then we can always educate staff and the family as well. So when you're doing the review and root cause analysis, again, if you have the antecedent behavior monitoring, 2 weeks is probably really good. You might want to do a little bit more if you're not really seeing a trend, just to see over 3 weeks is something else popping up. There is an ABC tool. It's an oldie but a goodie. It is you can download it, but it helps you to understand and respond to these behavioral symptoms. Okay. And then another tool that I'll show you is interviewing staff regarding the 20 questions. You might want to do this as a in-service, but it's 20 questions that you ask the staff so that they can think about how would they respond if these things were happening to them. And it can help to sensitize them or help them to understand why someone might get agitated and physically aggressive, as well as my Alzheimer's story or the life story. The life story is really helpful because it helps us to understand the residents' past and really who they were, what their personality was like. So this is the back to the ABCs. Okay, like I said, it really is an oldie but a goodie. It's been around for a number of years, but there's a lot in here. And so that's something, if you're interested, you can certainly, it's from the Geriatric Mental Health Training Series. This is the 20 questions. Now, you probably can't see this all that well. But, what would you do if you were in their shoes? One of the questions here, how would you react if people told you it was daytime when you knew for a fact it was the middle of the night? That may be the resident's reality. What would you say if someone came and took your dog or cat away? So this helps people to try to understand different things that might be happening in the resident's life and think, how would you feel? So it's a nice tool that's put out by the Alzheimer's Association. And then the benefits of a life story. So it helps us to understand more the meaning behind what the resident might be saying, helps us to understand the behavior better, and really helps to reinforce that resident-centered care that we want to do with the resident and the family. So this is an example. There's lots of these that are out there. This is just one that comes from a QIO, and it says, get to know me. Okay, so, name and, sometimes I get upset about, I need reminders. When I am upset, you can help me by. Okay, so the residents may not be able to give you all these answers, but the family can be a big help. Maybe when I get upset, you can help me by not leaving me alone. Okay, that might be one thing. Or it might be, holding my hand. So different things that we can find out. So it helps us to know what interventions might work with the resident. Okay, so there's lots of things on here. Like I said, there's different versions, and then there's different ways of using the life story. Some people will put the information into like a journal that they keep at the resident's bedside. You might see a storyboard or a bulletin board that has a lot of these aspects of what the resident was like, what they like to do, sometimes a shadow box. I always like that because you can see maybe someone's a big baseball fan, or they were in the military, or they were a teacher or a nurse, or, a homemaker with 5 kids. It really helps you to get to know that person better instead of, 201B that has dementia and behaviors. So told you I was going to bring Betty back. Okay, so she wanders and goes into other rooms. It's because she can't remember the location of her room. She refuses to eat in the dining room. Her hearing aids are set on high and the sounds are very shrill. She takes her clothes off because she's hot. She refuses to get out of bed or have her brief changed when incontinent because she's very embarrassed and she's trying to keep her incontinence private. She angrily accuses staff of stealing. She can't keep track of her belongings. She stays up late and wants to sit at the nursing station. Well, guess what? She was a night shift nurse, so that makes sense. She has a bad mood in the morning, lashes out at staff, trying to get her up. Her arthritis is very, very painful in the morning. Now, this is one to think about. Okay. Are you giving it? When is the routine pain meds given? Is it like 9, 2, and 5? Think about if residents are having pain, can we give that first dose at 6 a.m.? So it starts to work before we're going to try to get the resident up or provide any care for them. And then she repeatedly asks when she's going home. Well, she does that because her family told her she was coming for a short break. So this helps to explain Betty, what's going on with Betty. So what are some of the interventions, the non-drug interventions that we can be thinking about? So I'm going to go through these with you. So the very basic is communication. Okay, we know that a lot of residents will have impaired verbal and cognitive skills, and they may also have vision and hearing deficits, but 80% of communication is nonverbal. So focus on the resident and be aware of the message that the staff is sending. So some of the things, and I don't know that this happens a lot, but one of the things that people with dementia say they really hate is a fake smile. So we want to be genuine with the patient. And I don't know that anyone does a fake smile, but they can pick up on that and they don't like it. The other thing is to think about giving, remember I said, focus on what they can do, try to give the resident choices. An example would be going in and saying, oh, it's lunchtime. Okay, so that's letting the resident know it's lunchtime. But think about if you go in and say, hi, Mrs. Brown, it's lunchtime. Would you like me to walk with you to the dining room? See, that's giving her a choice. Okay, getting her involved in the care. So try to think about how you might be able to do that. If you go in, even dressing, I think we do pretty good with this. Would you like the blue sweater or the green sweater? That gives the residents some control over their environment. So some vision tips, make sure that we're trying, if you can, get them regular eye exams and that they have the right prescription. Make sure the glasses are clean. Are they really scratched and the resident can't even really see out of the glasses? So taking a look at that. Are they using the right glasses for the activity? Reading glasses versus if they're far away and watching TV or walking. And FYI, multifocal glasses, bifocals, progressive, trifocals, can increase falls. So if a resident has those, and you might want to think about if that's contributing to the falls. Colored toilet seats or plates can help a resident. And then certainly the environment. We want to make sure that trying to minimize shadows in the environment, and we want to get rid of clutter and obstacles, and then closing the curtains and blinds at night as well. Now, this is very interesting. A study was done, and it was actually pretty depressing, that staff communication, that they're focused on getting tasks done. Now, we know we have our assignments, we have to get our tasks done. But the study showed that the staff, a verbal response from the resident wasn't needed. Okay, so they didn't think it was important to interact with the resident. And what they found is that when you're focused on tasks and not really engaging the patients, they're going to get more withdrawn, depressed, they're negative attitudes, they have a decreased sense of well-being, they might feel like an infant. Okay, like I said, cutting up the food at the table is one thing where you can, be treating them like a toddler or an infant. And if you had a positive and friendly approach, it increased the resident's mood tremendously. So what are some of the things we can do? We know we're supposed to knock on the door. Okay, slow down, listen to the resident. Okay, try to use a soft voice, offer choices, nonverbal language. If you're sitting there and tapping your foot or like this, that is not open and engaging with the resident. You want to sit down and be at eye level as much as you can, an open body posture. Don't stand over the resident. Okay, nobody likes that. We don't like that. The residents don't like that. And then if a resident is having some behaviors, have one person at a time interacting with them. Sometimes we have 4 or 5 people around the resident, and it's more like a show of force, and it doesn't really help to solve that behavior problem. So those are some tips. Here is a quote. Um, I get emotional when I read this anyways, even though I read this so many years ago. But what dementia residents have said this: as we become more emotional and less cognitive, it's the way you talk to us, not what you say, that we'll remember. We know the feeling, but we don't know the plot. Your smile, your laugh, and your touch are what we connect with. Sorry, it really gets to me thinking of how a resident is saying this. And then one of the easiest ways to become angry is to perceive that someone's treating me like a child. So what are some of the interventions that work that are non-drug? Okay, I'm going to talk a little bit about music therapy, touch and massage, pain management, and aromatherapy. Not pain management, might involve some meds. But music over medicine. Okay, the memory for music remains intact, and songs are memory stirring. Okay, so music that is significant to a resident will evoke these memories for them. If they hear familiar and preferred music, those memories will follow. If it was when they were 30 and going out and dancing and having a great time, those songs will evoke that memory, and the patients will become you can see it in their faces as far as the happy memories that they have. And whether you sing or you play the music. Now, all these are researched, evidence-based. So these studies say 30 minutes 3 times a week is what you need. And it works, but especially if you've been doing it for 3 months. I've even seen nonverbal residents start to talk after using this music therapy. So you want to develop a playlist, and you want the right playlist. Their favorite artists, maybe 5 to 7 songs per artist and 100 to 200 songs. Okay, so you're going to want to talk to either their friends or their family to try to figure out who were their favorite artists. You want something that's easy to use for them to listen to the playlist, and you'd like them to have a headphone, but over-the-ear headphones work better with people with BPSD than something that's stuck in their ears like earbuds. You want to be patient. Sometimes if they're not getting into the headphones, you can just sit there and sing along with them or use a speaker and ease into headphone use. And you want to keep it special. I mean, you don't want this every single day that you're putting it on the resident. So it should be during, you can use it to promote relaxation. If we know that going to the shower is problematic for the patient, you might want to use it before we try to shower a resident, or if you know there's a pattern of aggression, you can sort of use it before to prevent those behaviors. With touch and massage therapy, our residents are so touch deprived. Okay, so when we use compassionate touch, it releases oxytocin, and this is completely hardwired from when you're a baby and you were being held by your mother. Okay, so touch does so much for these residents. They recognize caring touch, and it will significantly reduce agitation. It's also relationship centered, proactive, and really cost effective. So when people are deprived of touch, They feel isolated, they get anxious, insecure, they mistrust people, and they have reduced sensory awareness. But when you touch them, it's like an opiate-like effect. It releases oxytocin, increases trust, caring, they feel safe. It reduces stress and anxiety. So the hand massage, there were 3 studies evaluated either 5 minutes or 10 minutes. And the hand massage was 5 minutes twice a day. Okay, so you can even do it as little as 5 minutes twice a day. But there was a significant decrease in agitation for up to an hour. Also reduced the frequency and duration of agitation with morning care, strengthened the relationship. They were more alert, they slept better, there was less withdrawal or wandering, and decreased the cortisol levels because they were testing the labs. Okay, so that's an example there. Slow stroke back massage. Now, I've been a nurse for a long time, over 40 years. And I was a student nurse, and in the first probably 10 years of my nursing career, we used to give patients a back rub if you worked the evening shift, it wasn't even all that long that we gave a back rub, but 3 to 5 minutes. And you move long, rhythmic figure 8 on the back. It promotes sleep, decreases anxiety, reduced wandering, pacing, resistance to care, and they checked the blood pressure and pulse, and it was in a state of relaxation. For the foot massage, this one they say is boundary safe. Okay, so if you have a resident that might not want to be touched on their back or their hands, you can give them a foot massage. What they did is, 5 to 10 minutes, but in the one study, they did 10 minutes for 2 weeks. Then they didn't do it for 2 weeks, and they evaluated the change in behavior. And guess what? All these things that are listed here that the foot massage can help with, for that study that did it for 2 weeks, and then they wanted to see the effectiveness of it, it maintained effects for another 2 weeks with those residents. So they saw less verbal aggression, wandering, and repetitive movement. And if you think about this all makes sense. If you've ever gone for a foot massage, or you get one yourself, or you go to the spa and you get a massage, we know all these things, but trying to think about incorporating it with our residents. And this doesn't take a lot of time either. I mean, you don't have to do all these, even if you just pick one, 5 minutes a couple times a week or a day. The other thing is aromatherapy. So it's calming. It can, again, evoke pleasant feelings. I listed 2 here because lemon balm is recommended in the morning to reduce excitability, restlessness, stress, and insomnia. I'm sorry, this should be in the evening here. But lavender decreases stress, pain intensity, and insomnia. So there's different ways you can do it. You can have a plug-in atomizer. Some of the studies with lavender, they had it on a little cotton ball that they put onto the resident's nightgown. You could do pillow spray. There's a lot of different ways you can incorporate this. So that's another thing to reduce anxiety and emotional disturbances. And in the studies that used this, every single resident had a reduction in their problematic behavior. It might not have gone away, but a reduction. Okay, so then I have, I'm going to go through these a little quickly. Remember, everyone's going to get the slides. But going through some of these things for you to try to think about. I think we've talked about a lot of this already, but I put it together for possible causal factors and then interventions to consider. So we've talked about a lot of this, but these are things that are associated. So to look at the causal factors and then the interventions. Like I said, we've talked, hydration is important too. But if someone having physical aggression, maybe a depression risk evaluation, can we do another PHQ on them? Looking at these things, sometimes a thermal bath, if you have one of those bathtubs that is with the jets, can be helpful. Okay, let's see. Here for pacing, wandering, and restlessness, we had a lot more possible causal factors. So they're over here on this side. Let's see if there's something different that we haven't really, well, they might have like a neuropathy. Oh, the end of shift phenomena. And pay attention. So at 3:30, the residents are sitting there. What do the nurses do? We're giving report. People are coming in. If it's cold, they're grabbing their purse, they're grabbing their coats, they're leaving. Well, what does a resident think? I need to go too. Everyone's leaving. Okay. So at the end of shift phenomena, if you notice that you have residents who are having some issues, try to make it quieter. Instead of bye, see you tomorrow, grab your coat, your purse, and leave. Maybe quietly say, I'll see you tomorrow, and then just sort of grab your purse and coat and leave, so that it's not like the patient or the residents thinking, hey, everyone's leaving. I need to leave too. So that's interesting. They might be lonely and looking for company. And then here, the interventions, I think we've gone through most of these already. But again, they're sort of lined up with the behavior that you see. Disinhibited behavior. So again, they might be taking off their clothes. That would be an example. They might have a skin irritation. They might be too hot. They might be confused about the time of day. Have you ever seen that? Person's taking off their clothes because they think it's nighttime and they're ready to get into bed, or they're looking for their nightie. Or they might be self-conscious or embarrassed with personal care. So these are some of the interventions. Again, fluids, if they're too hot, are they a little bit dehydrated and they need some fluids, layered clothing. Okay, I think we know some of those other things. Calling out and repetitive speech, lack of a relationship or connectiveness to the environment, anxiety. It might be frightening, as we mentioned, some of those things going on the TV, or speech as a form of self-massage. Okay, it's relaxing to say, help me, help me, help me, help me. So the patient's trying to self-soothe themselves with that. So transforming the care environment. We talked about all that stuff that staff can do, the environment, just being with the resident. And I know sometimes this works. I'm sure you guys do it too. Sometimes you just bring the resident and put them at the nurse's station, and they're so much better. They're just sitting there. Okay. Or maybe just holding their hand can help. And then certainly checking for other things if they're in pain, incontinence, or other distress. And then the sleep disorder, it could be their circadian rhythm. They might have problems relaxing. That's where that lavender is good. It might be some adverse effects of medication. Like Prozac, you don't want to give that at night because it wakes you up. So that's again getting the pharmacist involved. They might have noise sensitivity or have pain. So we know we should avoid the daytime naps. Really, resident has to no more than 20 minutes, but access to daylight or blue wave light helps you with your circadian rhythm to be more in line. So either getting outside, or if you're having any kind of blue light in front of a window might help those residents. Tryptophan producing foods as a nighttime snack. Earplugs. Sometimes earplugs are helpful to a resident because they don't hear all the noise if they're really noise sensitive. Okay, so really the most effective nursing interventions when they've looked at everything is avoiding noise. So I was actually on site in a center yesterday, and I'm like, and it was huge, almost 400 beds. And I'm like, it's so quiet. And it's because they didn't have any overhead paging. You didn't hear call bells. I mean, they were silent. You didn't hear the phones. So try to think about that. And then the next, all the rest are right around the same here as far as the percentage of effectiveness of meeting toileting needs, communication validation, walking or physical movement, and hydration as well. Okay, so here's a couple other patients and what's going on with them. So Ruth was incontinent, but hits the CNA trying to help her. Oh, what she's saying is, I'm so embarrassed. I need you to be tactful and kind. George is banging on the garden door, shouts when staff ask him to sit down for lunch. George is feeling like a prisoner. I just need to get out into the fresh air for a while. In the dining room, several people are talking loudly. There's music playing. Sherry bangs on the table and screams. What she's trying to say is, I find it hard enough to think straight anyway. I can't bear all this noise. Bill struggles with a puzzle, swears loudly, and throws it on the floor. I feel so useless. I need to do something that I can do, not something that reminds me of my failures. And then Carrie kicks and spits at a CNA who's helping her get dressed. I don't know who you are. I don't understand what you're doing to me. And I don't know why you aren't letting me do anything for myself. So again, these are good things that you can share with the staff as well. Now, I do want to talk a little bit here. Has anyone ever done a virtual dementia tour? Okay, and you can Google it. There's a couple out there. It is incredibly powerful. I went through it about 20 years ago and still get goosebumps from the experience. It really is very emotional. But these are some statements from families can do it. You can do it with staff, and it can be helpful with families, especially if they don't understand. So basically, what a virtual dementia tour is when I did it, there was a room set up. They put like things so my vision was impaired. I heard all this noise because their thoughts are jumbled. They gave me gloves, they put something in my shoes, and then they told me like 5 things to do, and I had to go into the room and try to do the 5 things. And believe me, I think I got 1 or 2 done because you just can't concentrate. It gives you an idea of what it's like to have dementia. And then the other one is this book, Dementia Beyond Disease. I found to be incredibly helpful to read and giving some ideas. And then there is the National Partnership to Improve Dementia Care. Okay, this is put out by a QIO, but there's all these different things if you're looking for resources, and here's the link. And then these are just a reminder of some of the things that we talked about with trying to help the residents. So let's walk with our residents in their reality. And Yvonne was monitoring the chat. And Yvonne, is there anything that came through the chat? Any questions?
Just one, and I answered it. It said, when will this recording be available to view again? So everyone will try to get it out early tomorrow for all of you with the slide deck. But anyone have any other questions now? Now would be the time to ask. Nothing coming.
Certainly. Oh, is
Nope,
there
nothing
anything?
coming in. Nope.
Okay. The other thing I want to say to you guys, my contact info is right here. So if you're trying to find something and you're not finding the link, you can reach out to me and I would be more than happy to send you the link, or if it's something I have saved as a document, I can do that if you're having difficulty finding anything. So I want to thank everyone for participating today, being on the webinar, and I hope that you gained a couple ideas from it that you might want to go back and try with your residents. Thank you.